I am in Winnipeg, Manitoba, Canada, with a very big role model. I'm icon of mine, Dr. Jack Lipkin, a prosthodontist.
Right.
What year did you become a prosthodontist?
1979.
So you've been a prosthodontist for how many years?
36 years.
36 years. And I really wanted to do this interview because of all the 9 specialties. Prosthodontist is kind of the most rare one. I mean, there's only about a thousand. How many are there?
Well, at one point we did a survey across Canada, which was quite a few years ago. There was like 130. Now there's more, but I would imagine 250. That's it. And most of them are in schools.
Yeah.
Teaching.
So first of all, just in case someone doesn't know, what is a prosthodontist and what made you become one?
Well, a prosthodontist is a specialist that is involved with providing prostheses for dentitions. They might be fixed, removable. And part of our definition is we were the original cosmetic dentists. And major full mouth rehabilitation, anything related to occlusion, TMJ, that's our specialty. Providing prostheses to replace missing dental parts, dentitions, and oral facial structures.
And I mean, in your own right, you really are a legend on this. And you also have a website where for 20 years, you've been teaching dentists all over the world. You basically have mixed continuing education with fun high-end travel, which I assume your wife had something to do with that.
Oh, big time.
Wanting to go on these cruises.
Yeah, she works hard at
it. Yeah, she told me she just got back from Galapagos Island.
Right.
She loved that.
And Machu Picchu, yeah.
So what is the website?
Kennedy, it's www.kennedyseminars.com.
KennedySeminars.com.
The official name of our company is Kennedy Professional Educational Seminars, and we've shortened it to Kennedy Dental Seminars or Kennedy Seminars. And we've been doing this for 20 years.
So the Americans are thinking Kennedy comes from John F. Kennedy, but that's not the case.
It doesn't. It actually originated from a street in Winnipeg where, it's a long story, but we were attempting to put up a dental specialty building on Kennedy Street. And in order to get things moving, we had to create a corporation, so they called it Kennedy Professional Center. And so we had this corporation, and then things progressed, and long story short, we couldn't get enough interest from other specialists in the city to move into this building and become part owners. It wasn't just moving in, but actually everyone having an equal ownership in building it. And so the developer was so excited, he built it himself anyway, because it was just, all the conditions were right. And after I did this with a good buddy of mine who's an endodontist in town, Wayne Atchison, and after the project didn't go anywhere, the lawyers called me and said, we have this corporation called Kennedy Center. What do you want to do with it? And it was like $500 to create this corporation. I said, well, I don't want to throw away $500, so let's keep it. And then we built this building, and even though it's on River Avenue, it's Kennedy Professional Center. So, and then everything after that had the name Kennedy attached to it. And an interesting story is when we wanted to patent the name or trademark the name, well, patent actually initially, we applied through the U.S. Patent Office, and I got a call from the Patent Office as they were reviewing my application, and they wanted to know if it was attached to the famous Kennedy name in the United States, because they were not going to have any part of that. So I explained them the story, and we had a little chuckle, and we got the name trademarked. But so there is this name connection, but not really connected to the Kennedy name. Yeah.
Kennedy is my mother's favorite president, only because he was the only Catholic president.
Well,
that's
actually,
my mom's only
Actually, Canadians were quite in love with him too. So
they were.
They were. Yes.
And why was that?
He projected a new era. He's young and vigorous and smart, and he was going to lead the Western world into a new and better place to live. That was our feeling when he got elected, and tragically his life ended way too early. But,
Well, speaking of new and young and vigorous and smart, what do you like to teach in your courses?
well, many, many years ago, it was the whole range of prosthodontics, from TMJ to restoring the endodontically treated tooth, crown and bridge, etc. And then implants came into being, and so gradually my lectures changed to involve more implants. I've been restoring implants since 1985. So gradually, as implant restorations became more popular and the science became better, my lectures started to switch more towards implant restorations. And probably in the last half a dozen years, it's virtually almost all implant dentistry. Although I'd like to get back to some of the other things: occlusion, restoring the endodontically treated tooth, dentures, removable. Very, very important parts of dentistry, because not everybody can have implants nor afford implants.
So, my whole motto with capturing the internet, now the smartphone, is that with Dentaltown, no dentist would have to practice solo again. So these young dentists are walking into these dental conventions, and they're at the largest dental convention in the world is the FDI in Cologne, Germany, every other year. Last year at Cologne, Germany, there were 275 different implant companies.
Yeah.
You're a prosthodontist. You've done this forever. If a dentist was going to buy an implant system, is titanium? Is it easier for you to restore some systems more than others? Do you have your favorites, or are you agnostic and don't care?
No, it's easier to restore some systems versus others. Surgeons then have their favorites. However, to every restorative dentist, what I want to tell them is that you are the quarterback of this treatment. And if you're dealing with a surgeon, you've got to play the quarterback role. And some surgeons have their particular favorites, and that's fine. But as a restorative dentist, you've got to be able to restore the case as you see fit. And the surgeon really is, in a way, a subcontractor, although it's a crucially important step.
I love it.
But the quarterback and the final, the final nail gets placed at the hands of the restorative dentist. So what I'm saying is that you have to work with a surgeon that's working with a system that you can work with. And if the surgeon is not, and you're not comfortable, then you can either learn that new system or find another surgeon. And in some cases, many dentists are placing their own.
So I'm trying to estimate questions they're asking. I'm sure some guy's yelling in his car right now. Just tell me your favorite system. Quit pussyfooting around.
Oh, I'm happy.
What do you?
Well, I started off. I mean, in 1985, we attended a Nobel meeting in Toronto. Professor Brannemark of late was there.
That was his company.
That was his company. The whole Swedish surgical team was there. And the whole Toronto team that had corroborated the Swedish research. So it was an incredible two-day meeting. There were dentists from all over the world there. And
to clear up some confusion, how did it go from a Brandmark implant to a Noble Biocare?
Well, initially it was called a Brannemark implant because he had developed it, and I think they wanted to put a more kind of generic name on it and unattach his name to the implant. That might have actually been his doing. I'm not sure. He was a very humble and modest man, a brilliant man. And so I don't really know. He might have wanted his name taken off of the implant. I don't know. So it became a more generic type of name. And so I took the course there, and then at the same time, Corvent implants were becoming very popular.
Corvent, that was
Dr. Jerry Niznik.
Jerry Niznik, who later sold it to Dentsply.
It's had many iterations. He sold it to Dentsply. Dentsply then paid him to take it back, is my understanding, and then it got sold and repurchased, and it's had many.
And then Jerry Niznik went on to Implants Direct.
Implant Direct.
And then sold that to Cybrun Kerr, owned by...
Yes. Is that
Danaher.
Danaher, right?
And now
and
the
then,
rumor is he's back.
well, I don't think Jerry's ever left. So
Yeah.
truly. So I think his heart is, and
Where do you think
soul is
he's going to show
still.
up next?
You know what? Well, I'll get to that story soon. So we started using Zimmer implants. Jerry has a Winnipeg connection. He actually went to school at the University of Manitoba.
Jerry Nizick did?
Yes, he did.
This is
Graduated
his
from
country, huh?
This is his country. Graduated from the University of Manitoba Dental School.
So he's Canadian?
He's Canadian.
Born in Canada?
Born in
I
Canada.
did not know that. I thought he was born in L.A.
Yeah, took his prosthodontics, I believe, from Indiana. Not quite sure. I think Indiana. If I'm wrong, then I stand to be corrected. And became a prosthodontist and went to Los Angeles and started working there. And he is a brilliant man, and
Extremely.
extremely. And the Nobel BioCare implant was out, and he looked at it, and with all due respect to the Nobel people, and they will tell you this they will agree with this, that at that time it was a surgically driven system. And the prosthetics was like, okay, you guys go over there and play with your teeth because the big boys are doing the surgery here. It was a surgically driven system, and they will all agree with that back in the early 80s, mid 80s. And Dr. Nisnik, being a prosthodontist, said, well, what can I do to make this more friendly for the average restorative dentist / prosthodontist? And he did.
That was Implants Direct?
No, that was Corvent.
Okay, that was Corvette.
1983, 84, 85. And then I took a course from Jerry Nisnik in Los Angeles in 85. And we started using that system. As it turned out, the internal connection, which was a much better engineering design than the external hex, which I don't think exists anymore except on the old style implants. So we actually engineered something that was better, easier to restore. So we started using it. Marshall Hoffer, my partner here in the office, and I started using it. And
why was the internal hex better than an external hex?
You know what? I'm not an engineer, but there was much less screw loosening. And again, not being an engineer, I can just give you my version. Is that for many years, when the external hex was being used, there were lots of studies on the number of screws and implants that would loosen, and they would come up with these certain percentages. And the Zimmer implants, it was rare for a screw to loosen. I think it was related to the Morse taper of the connection. And so we started using Zimmer implants and had a phenomenal success rate with them over 3 decades. And now, lately, Zimmer Dental Implants was bought by Zimmer Orthopedic. Zimmer Orthopedic, I think, was less interested in that little arm of their company as a business. The orthopedic was just, that was their main business. And just in the last maybe half a year, they've either merged with 3i Biomet or sold out to 3i Biomet, but I'm not really sure where it's at, but everything is called 3i now. And so I think the Zimmer implant, I believe, is still around, but it's 3i is now the company that has it. And in Canada, 3i had its own customer base and its own culture, and Zimmer had its customer base, and I think now they've merged together.
Another common question we get on Dental Town is they're confused about platform switching. Could you say a few notes about that?
You know what? I think it's much ado about not much. I mean, the whole key is making a proper diagnosis, which takes some time. Communicating with your surgeon, having a proper cone beam CT taken with a radiographic stent, or alternatively using any one of the systems that are out there, being able to place implants right on your CT and getting the size and the angle, et cetera, and then planning an implant that's going to go into that space, and then you've got what you've got. So to me, that was, I know it was a huge deal, and I just didn't really, I never got involved with it. I didn't really need to. Whether I was doing a single unit or a full mouth of implants, I knew exactly what I wanted to get, where I wanted it, through, proper radiographs, through proper clinical exams, my clinical exam, the surgical clinical exam, which is crucial. I would meet with the surgeon, go over the scans, mounted casts, with radiographic guides, and we would just plan it out, and we knew what we were doing. We knew what we wanted to get. So that's
So, do you have any favorites on CBCTs or surgical guides or implants or?
Well, my answer to your question about the implants is that I've been using Zimmer for 30 years, and I use Nobel in particular cases. And
So Zimmer's your
so Zimmer's my mainstay, although I
favorite.
don't really know what's happening with the company. I'm very comfortable with Nobel. I've restored a few Straumann, which I loved doing, so I was very happy with that. And I have a lot of friends who are doing Implant Direct who are extremely happy. So those, those would be the classic four that I would.
So Zimmer.
Zimmer, Nobel, Straumann, Implant Direct would
So
be the
you ever
classic.
so
And I have not restored any others.
Jerry Niznik is he's the Manitoba prosthodontist. Do you think he's going to be back in the implants?
Well, he's got his heart and soul in it, and I think it's entirely possible.
He's spent his whole life in dental implants. I can't imagine him ever saying, "I'm done."
Exactly. And
So
he's a brilliant marketer and brilliant marketer.
So, you're talking to thousands of general dentists. That's mostly anytime anyone emails me or whatever. It's usually a general dentist, and they're usually very young. They're usually within 5 years out of school. You've been doing prosthodontics for 37 years,
36.
36 years. Most of these kids have been out of dental school less than 5 years. What words of fatherly advice would you give them? Of what are common low-hanging fruit prosthodontic advice you could give them to keep them out of trouble?
I think the key is examination and diagnosis. I think it gets treated half-heartedly. It's slipshod. And when I give lectures at the dental school here, it's the first thing I say is that you need to do a proper exam and diagnosis, take casts, mount them, proper set of x-rays, a full exam.
But you're talking about for a complex case or
Well,
for what are you talking about?
Well, I'm talking about most cases, because the problem is that if you're asking me to give advice to someone who's been out for 5 years, what I'm going to say is that it's amazing how many times someone will, see a tooth that needs a crown and stunningly not really look everywhere else and get focused on that one particular tooth, and then suddenly, before you know it, it's prepped, and there's a problem. There's either a problem with the opposing arch, perhaps the tooth is super erupted, not enough was removed. I see this all the time. I see mistakes constantly being made by young practitioners because the examination took 10 seconds and they jumped in and started working. and then suddenly the impression is made, it gets sent to the lab, and there's a problem of whatever description. So I think if in your first 5 years, I think if someone needs restorative work of almost any kind, single crown to whatever, I think impression should be made, mounted, proper exam, perio exam, which is crucial. I tell the students when I lecture them, the first instrument you should pick up is a perio probe, and then obviously proper charting. And when you look at those mounted casts, and it changes your whole perspective. Sometimes it's straightforward, and then you've got a set of mounted casts, and you've got the opposing cast, and away you go. And quite often it isn't, because it gives you a whole different perspective. So that would be my first strong suggestion to new graduates. And I tell the students that I lecture to, you need to look, you need to think, you need to assess what's going on, you need to ask, and ask means ask your patient, ask your staff, ask the dentist that the patient came from prior to seeing you. Ask can mean anything, but get information, and then action is the last of the five. And this is what I tell the third year class when I lecture to them, is that you're actually doing something 5 steps down the road. Look, think about what you're looking at, assess the situation, ask, and then act. And act might be whatever. Act may also mean not treat them. Saying no is an option. The patient saying no to treatment is one of their options. Now, unless people have a right to make bad decisions for themselves. You don't want to hear that, and you don't want to see that, but they do. And so saying no to a treatment plan is an option a patient has, and as per your lecture yesterday, many people exercise that. And a dentist saying I can't help you is also another option. But setting that aside, those are the 5 steps that when I lecture to students, that's what I tell them. And another piece of advice would be, don't be the first person on the block to buy the latest and greatest and all that, because I think that's a mistake. And a lot of companies are out there pushing products that haven't been tested properly. And you just don't want to be the first person out there grabbing onto something. And I believe you mentioned that in a lecture as well. I've heard you lecture before. You mentioned that in Calgary, and I think it's great advice.
So you've had a very successful prosthodontic office for 36 years. Do you talk about your high-end technology? Do you own a CAD cam? Do you own an optical scanning for impressions? Or
No. We have a dental lab down on the main floor. We have a iCat machine here.
And the iCat's a CBCT,
CBCT.
owned by Danaher.
Yeah.
But what I'm getting at is my prosthodontist friends. I generally don't meet prosthodontists with CAD cam CEREC machines.
I don't have one.
Yeah. And
Yeah,
so you're looking at students that have $350,000 student loans, and due to marketing and pressures, they feel like they have to have one.
Yeah.
And I'm sitting here saying, okay, here's a really successful prosthodontist for 36 years. He doesn't have one. So tell him how you were able to be a prosthodontist for 36 years without a $150,000 CEREC machine. Is this? Do we call this the miracle of Manitoba?
No, it's not a miracle in Manitoba. I have a referral-based practice, and so people get referred here, and and for examinations, diagnosis, treatment planning. So I treat what comes in the door. Dentists are not going to refer patients to me that need a couple of veneers, and nor should they. So I typically get patients that get referred that have complex dental issues, and it doesn't mean their entire mouth. It could be a mouthful of teeth where they've been unable to chew on one tooth for a year, and no one can figure out which tooth it is. So it doesn't have to be a full mouth of teeth. And I do the traditional tooth preparation, making a temporary, fabricating a temporary, taking a polyvinyl impression, and having the typical, dental laboratory technician wax it up. We do a lot of PFMs, porcelain fused to metal. I use gold, and I'm doing some all ceramic crowns, and that's the nature of my practice. And if you're in that kind of debt, to me, someone who's graduated in the last 5 years, they need to get their skills up. They need to get their skills up. And to me, that's where you start. You got to watch your debt load. Debt is extremely injurious to anyone's financial health. Some debt's important, but you need to get out of debt ultimately. And so you need to get your skills up. So just start the traditional way. And if it works for your practice, ultimately to buy a CEREC machine, then maybe do it down the road. But
Are you impressed with the quality of crowns you're seeing out of CEREC, out of CAD/CAM machines in your backyard?
oh boy,
in Manitoba? This is Dentistry Uncensored with Howard Farran. We don't sugarcoat anything.
well, I can't speak about CEREC because I actually don't see them. I don't really see them. I don't have a machine. There's a few dentists that in town that are doing it, maybe more than a few, and I've seen their work, and it's very nice. So from that standpoint, they're nice restorations. They're good restorations. Some of the CAD/CAM crowns that are made, I would not cement personally. I have colleagues really around North America that travel with our seminar company that are not terribly thrilled with some of the results they're getting. And of course, it's a very, very controversial, it's at a very controversial stage right now. And so from my own standpoint, personally, I have not been happy with some of the quality that I've seen. I know dentists will tell me, well, if the margins are open 100 microns or so, that's sort of okay. Using an appropriate cement, and perhaps it is, but so I have mixed views on that right now. I'm sticking with the tried and true.
I want to ask you another question. My deal with Dental Town is that, these people are all alone and trying to connect them. A lot of these young kids are confused because they feel like they should pursue their education, learn about occlusion, and there's very distinct camps. You have LVI in Las Vegas that talks about neuromuscular occlusion.
Yeah.
Then there's these Dawson, Pankey, with other types of occlusions. Is occlusion? These people have to pick a camp. I mean, should they go neuromuscular? Should they go more Pankey Dawson occlusion? And then there's people out there that say, you know what, the occlusion, all those camps they're like religions. People just believe stuff with no evidence. Is occlusion voodoo? Is occlusion religion? Or is it science? Is it more neuromuscular? Is it more LD Pankey? If you were talking to your 30-year-old granddaughter that just walked out of dental school and she said, "Grandpa, I want to study occlusion," what would you tell her to study? Or would you even tell her to study it?
Well,
And
no.
at this point, you just want to leave the lecture. The interview.
Exactly. I'm looking for the closest escape hatch here. Well, occlusion is very important. I think some camps have turned it into a religion. I stand very strong with some of the science that has been out. Teeth come together, and they touch. You hope,
But not when they chew.
right? So that's right. Up until perhaps that last bolus of food is down to maybe tiny little, thin little pieces. So. When I first got back from graduate school, when both of us got back, Marshall Hoffer and myself, we were asked, well, what occlusal scheme do you subscribe to? And it was like, well, we don't. Okay, we don't have an occlusal scheme that everything has got to fall into that pattern. So if I had to, right now it is, and I'm going to create a lot of controversy about this.
Fantastic.
But right now, it's my opinion, based on the best literature that I can read, that the neuromuscular approach, in my opinion, doesn't have the science behind it that would work for me. Okay, and I know that there are people that are doing it, and that's fine, and it's working. It might be working because man is a highly adaptive organism. So I don't subscribe to that.
No, go ahead.
If I had to pick something, I would pick the Dawson Pankey, and I think that they give great courses down there. But the thing is that you need to go down there and take a course and take out of it what is going to work for you and what makes sense. And you need to read and all of the books on occlusion, and you need to really, when you get back to your offices, you need to really thoroughly examine your patients, and this goes back to examination, diagnosis, and treatment planning, and you need to start thinking about what it is that you need to do from an occlusal standpoint, and what is it about occlusion that really you don't need to worry about. Because, as a prosthodontist, I look in people's mouths every day, and it is so highly variable, and people are functioning fine, and there's no pathology, and they'll have a contact here and a contact there and another contact here, and they're 70 years old, and they've got a healthy dentition with no pathology, and you look at that, and that doesn't fall into any occlusal scheme. And so suddenly you're asked to, put in a crown for that person. Well, of course you want to have some ideas about the type of occlusion you want on there. To me, you want to load it along the long axis of the root, if possible. You don't want to have balancing interferences. Depends on working excursions, whether you want to include the tooth or not. So there's all some basic concepts that you want to follow. But the answer to your question is, I don't think you want to fall into a camp. I think you want to look at this, look at the rationale behind it, read about the histology and pathophysiology of the periodontal ligament, learn about force generators and force direction, study about the TMJ, and each practitioner will end up having their own scheme within a scheme, for lack of a better word, and they'll do what works for them, and as long as you adhere to some of the basic principles. Long answer to a question.
Is it overly cynical for me to feel that some of these TMJ camps will get a device, a measuring thing, have a deal, because when they get done with a diagnosis and treatment plan, the only way they can fix you is crown all 28 of your teeth, and that seems to be more about big money. Am I very cynical saying that, or have you felt that sometimes over the years?
No, I agree with your cynicism. I think that TMJ is a whole different topic, and when it comes to that, I really believe you need to really delve into the literature and look at the literature and look what it's telling you, look what it's not telling you, and try to understand that the jaw joint is probably the most complex joint in the human body. It's highly adaptive under crazy circumstances. You can abuse the heck out of it. But people that, and I've been asked to adjudicate cases where patients got into a car accident, and were hit from behind by a car going 100 kilometers an hour, 60 miles an hour, and whiplash, the whole gamut, soft tissue injuries, and then they develop TMJ. But quite frankly, their problems are way beyond that, and they get into hands, and I've seen this. I've seen these cases come through, various insurance companies that end up landing on my desk, and they'll have a full complement of teeth, and they were doing quite fine before the accident. And next thing you know, someone is suggesting they crown 28 teeth in their mouth in order to treat their TMJ problem, and it's just not reasonable or rational. And there's nothing to suggest that those crowns are going to help that person in that type of situation. And there are many offshoots of that as well. So my TMJ treatments are extremely conservative, extremely conservative. I send a lot of patients out for physiotherapy, physical therapy, because a lot of it is soft tissue. People who brux or clench obviously need a processed night guard, which I make, which in my view has to cover all of the teeth.
Top or bottom?
I make top because it's just much easier to develop the most ideal occlusal scheme that you can, in my opinion, in my hands. Although bottom splints work equally as fine. And but the key is to cover all the teeth. So because I've been called in to treat people who are wearing these little unilateral splints, or splints that just cover a couple of teeth.
NTI?
Yeah, or whatever they're called, splints that cover, there's many different iterations of it that cover a couple of teeth. And 2, 3, 4, 5 years later, their occlusions are an absolute mess. And so to the same group of new grads, think about what it is that you're doing, and follow established practices. Follow established practices before you get out onto some ledge because you went to a lecture and you heard something and it sounded cool. Follow established practices, get your skills up. Patient bruxes, well, they need a splint, and established practice is to fabricate a splint, upper or lower, I make uppers, but whatever, that cover all of the teeth with a proper balanced occlusal scheme, etc. Have the patients wear it at night or during the day, or whatever the diagnosis is. But those are that's sort of the standard approach. The classic TMJ patient, I think the word is being often overused, for lack of a better word. So.
Okay, I want you to answer this question for her. I know she asks a lot. When can I just take when is it okay to just take a sideless premier triple tray impression? When do I need to cross the line and take full upper lower impressions? And when does it cross the line where I have to get out a face bow transfer and mount this cast on a semi-adjustable articulator?
Well, there's literature out there that the triple tray works fine, and again, there are practitioners that I've used it once because I wanted to try it out. Okay, but there's lots of literature out there that support the fact that you can get very well fitting crowns. I think that if I had to pick some criterion. You want to have a lot of occlusal stops on the teeth in the quadrant and the opposing quadrant that you're working on, so that these things, can get, mounted properly. If you're working on a posterior molar and it's the last tooth in the mouth, let's say a lower right second molar, and then the next tooth is a first bicuspid, and then a cuspid, I think you're better off using a tray that will capture the whole mouth. I think you'll end up with, consistently a better result. Although people are doing the triple trays there and they're saying it's fine, but when I hear that, I don't know what it's fine means, quite honestly. So that would be one of the criterion. If you're missing a lot of contacts and it's a terminal tooth, I would take a full tray. If you've got a full complement of teeth and you're doing a single crown or a couple crowns, then I think the triple tray is fine. But it's new students, and you speak to labs around and they will tell you, new students are having trouble taking impressions that show the margins. So to me, it goes back to the beginning for these new grads, 0 to 5, get your skills up. Learn how to take a great, excellent impression that captures all the detail that you want to capture. Then go ahead and use your triple tray. But the problem is that they're trying to pay the bills, they're getting busy, they're, in my opinion, rushing, trying to do the latest and the greatest, and they're not getting the basics done. They get out of school, how many crowns have they done? 2, 3, 1, some schools. That's a whole different story. So next thing you know, they do 1 crown or 2 crowns in the school under supervision. Now they're out there and they want to do a whole bunch of crowns, and they hear this triple tray, and I talk to labs all over the country, and it's like they're getting impressions that are not readable. So you need to go back and say, okay, where is the issue? It's not the triple tray. That's not the issue. The issue is having a proper preparation, learning how to pack retraction cord, learning how to take a good impression. So you have to get back to the bottom
So what
line.
is your favorite impression?
So-
Are you a polyether man?
No,
Are you
I use
polyvinyl?
polyvinyl, and I use polyvinyl. I use extrude and
Who makes
imprint.
extrude and imprint?
Yeah, and imprint.
Is that what brand?
Extrude is Kerr.
Extrudes Kerr
Kerr.
and imprint.
Yeah, I'm not sure. Yeah. But getting back, so that's that. Now, if you're doing, multiple crowns, you want to have a full tray. And to me, they should be mounted on a semi-adjustable articulator. Where you want to get into a face bow is where you could make an argument for doing a face bow for any posterior crown, because the face bow just translates the arc of closure. That's what it gives you. So you could make an argument, and I wouldn't do a face bow for single crowns, but you can get inexpensive Hanau articulators that have a little jig that you screw onto the bottom mounting plate that you put the upper cast on that simulates the position of a face bow. It's obviously not the same, but it's very, very close, which I use all the time. So you can do that, and it's maybe 2 extra minutes in the lab. So you mount the upper cast first on a jig, lining it all up. It's all been engineered to simulate a face bow. And then so you're not obviously doing the triple tray here. You're now doing 2 separate impressions. And then you mount it, and then you've got something even closer than it would be if it were a hinge, obviously. And then the major full mouths, those are the types of things you would want to take a face bow on. Or where if you're doing 4 crowns, let's say lower right, cuspid, first by, second by, first molar. There's no second molar, okay? Doesn't seem like a lot, but you're changing half the occlusion, really. So it doesn't take much to get to a point where you're really making a major change occlusal scheme. So you need to look at that and say, this isn't just 4 crowns, but I am now getting involved in half of this patient's occlusal scheme. And depending on what's going on the other side, it might even be more than half. So it doesn't take too many units of crown or bridge to affect some major changes, and sometimes it can turn out negatively. So in that type of case, you might want to take a face bone. So it all depends on kind of where you're at. Personally, I don't use the triple tray. I take I'll take a full tray and I'll cut it on the opposite side to what I'm working through the cuspid and bicuspid. So I'm going to capture 2/3 of the arch, and then I'll do an opposing the same. So that's about the smallest tray that I will use.
And what about cementing your PFMs?
Oh, zinc phosphate. They did, and this study goes back a number of years, but they did a study where they surveyed general dentists and specialists, prosthodontists, and the vast majority of prosthodontists at that time, and the survey goes back a few years, were using a zinc phosphate type of cement. And it was just very interesting. And the general practitioners at the time were using resin-modified glass ionomers, things like that. For my cases, I use zinc phosphate. I use resin-modified glass ionomer for my all-ceramic crowns. And those are my 2 cements. And the reason I use zinc phosphate, I do a lot of PFMs. I do their bonnet. The crowns are porcelain bonnet to gold. I use a high noble alloy from Jensen. And as often as I can, I will use a small metal collar on the labial and on a beveled edge, 45-degree bevel, something like that. And we have our own lab downstairs. So our gold technician downstairs is outstanding. These crowns fit beautifully. Zinc phosphate cement has stood the time for 100 years. It works, and I don't have the need. I could use resin-modified glass ionomer. I'm fine with what I'm using.
And isn't it the least water soluble?
Yes.
And it also has a bacterial static component with the zinc.
Yeah.
So
it's the least. It
was always a red flag to me when we were talking about other cements. They're saying, "Oh yeah, this cement is good. This cement's good. This cement's good." But if it was a mandibular second molar and you didn't know if you could have it dry all the way, and there might be recurrent decay, you definitely want to go zinc phosphate. And I was saying, well, then why wouldn't that be your first choice on every crown?
Yeah, and
I mean, if it's what you need when the going gets tough, why wouldn't you use it everywhere?
and I mean, you can imagine what gets referred to the office. Okay, so I deal with treating mandibular second molars and maxillary third molars and some mandibular third molars where the teeth have decayed into the furcation. I mean, this is what gets referred to me. So when someone says, well, I don't know if I can get a dry field, well, I say to myself, get a dry field. And if someone says, well, I don't know if there's still decay there, make sure there's no decay there. Like, I don't understand that thinking at all. And it takes time to do this. You're working on a third molar or a second molar that's decayed down the distal to osseous into the furcation. Take the time to fix it properly or refer it out. Refer to a prosthodontist in your area that will deal with that. But the comment that, well, I'm going to use this cement because I don't think I can get it dry, I haven't had that issue. I can't not get an area dry. It might take me a little time. So when I get a case like that, we live in prosthodontists live in a different world. I might need an hour and a half just to get the decay out and make a temporary crown. It might take me that long because of the access, because of patient issues, if that's what I'm doing. And I know darn well they're off for perio surgery after that. And our periodontists love it our periodontists love it when they get a case where there's a temporary crown, because they like doing the taking the temporary crown off, doing the perio surgery, re-cementing the crown back on, suturing around the temporary crown. They love getting cases like that. So if I can make their job easier and ultimately mine, that's what I will do. So it's not uncommon for me to be treating a tooth like that and taking that much time just to get a temporary on.
So tell me this. Most of my periodontist friends tell me
Yes.
that if they practice in a 5 mile radius, it's like 10% of the general dentists refer like 80% of the crown lengthening. And so you're talking to, there's dentists out there who they do that all the time.
Right.
And you're talking to other dentists out there that haven't done it once in the last 1, 2, 3, 4 years. They haven't done it one time.
20.
Or 20. So talk about that. Why do we see that? Why do some people never do it? Some people do it all the time.
Well, my question is, for the 80 or 90% of dentists that are not referring out crown lengthening, my question is, what are they doing? Are they doing it themselves?
No.
So they're ignoring it.
Mhm.
Okay. Well, to me, that's not proper practice.
Okay, explain that, because it's huge in America. It's huge. I
Well,
don't know if it's huge in Canada, but
I assume that there's a lot of similarities.
So what are you seeing why you do crown lengthening, and what do you think they're not seeing if they're just not doing anything about it?
Well,
Or seeing it?
if you have decay down to osseous tissue, okay, I don't know how you can have put a crown over that tooth, which invades the epithelial attachment, and not have chronic inflammation down there. I don't know how you can do that. So when you're invading the biological attachment like that, you need to do a crown lengthening. Now, I think in my opinion, you need to do a crown lengthening. I think periodontists would obviously agree with that. Now, so I guess my question are not, according to your statistics, 90% of the dentists that aren't referring, if they're not doing the surgery themselves, which they're taught how to do in dental school, and they can certainly do it, and maybe they should consider doing it. If they're ignoring it, that's not proper practice. So if that's being ignored that often, that's not good for the patient, not appropriate treatment, not healthy for the area or for the patient, and it's not proper practice. That's what's happening. So I would be, if that's an accurate statistic, I think it's sad that that's going on, actually. So, and then there's various levels of it. So in my practice, I will look at the situation, and if I have got a problem, let's say, for example, decay that leaves me with a very, very, very narrow sulcus or shallow sulcus, and it is quite deep subgingivally, I might say to myself, well, I can restore this, but it'll be a much healthier area if we do the crown lengthening. And I can tell you that when I get these crown lengthenings back from periodontists, it's a whole different tooth. It's a whole new deal. You've gone from something compromised to something that is just so clean, and it'll be easier to maintain, easier to look after, healthier tissues. It's a much better treatment. And after 40 years of practicing dentistry, 36 6 as a prosthodontist, I still look at these coming back from a periodontist where the crown lengthening has been done, and I'm saying, oh, wow, I'm glad we did that, because this is just a clean, great situation that's going to stay healthy for hopefully a long time.
In your 36 years, 36 years ago, implants was kind of experimental, wouldn't you say? I mean, there were blades and subs and Ramus bars. And,
Yes.
And a lot of the early guys doing it were kind of badmouthed by their peers as being crazy. And it was a lot of bridges and removable partials.
Right.
Now that implants are more mainstream, is the 3-unit bridge going to go the way of the dinosaurs?
Well, it's certainly going that way in my practice, because when you look at the statistics, and some of the best articles to read are from Dr. Charlie Goodacre. When you look at this,
Where is he at?
he was the dean at Loma Linda. Mm-hmm. He is retired, but he's still in dentistry. A wonderful man, and just.
You think you can fix me up a podcast with him?
I think he would probably do that.
Well, do you email him?
I could.
Yeah, email him and CC me, Howard at dentaltown.com.
Okay, I will do that. Wonderful man.
Down there in Redlands, California?
Yeah, Loma Linda.
That's where I take my boards.
Okay.
And that's the oldest living zip code in the United States.
Oh, is that right?
Did you read the book, The Blue Zone?
No.
The Blue Zone is studying around the world. There's 10 cities that have 10 times the amount of people living to be 100, and they all have the same thing in common. They're mostly vegan. They're religious. They it's very interesting. But the only place in North America is Redlands.
Yeah.
They're Seventh-day Adventist, so they eat a Old Testament biblical plant-based diet.
Yeah.
They also don't have many amenities like cars. It's more a walkable society. They're more likely to walk to the grocery store every day and walk back with day's food.
He's a wonderful man.
Yeah.
Wonderful man. So his articles are, I think if you want to read a collection of articles, his are the ones to read. And so the 3-unit bridge, I think, is going the way of the dinosaur. I think an implant placed in the edentulous space is a far superior long-term treatment. And again, missing a lateral incisor, last thing you want to do, in my opinion, is a bridge from a cuspid to a central. Is an implant in the lateral incisor, all things being equal, okay, because there are exceptions, an implant is a far better treatment. And I've gotten to the point where if someone young comes in, a teenager, 16 to 19 or 20, and they're not quite old enough to have an implant, but they want that space filled, I will do, in order to preserve the integrity of the cuspid and the central, I'll do a Rochette bridge, very conservative, Maryland-style bridge with holes through the wings, a Rochette bridge, and you can get it off. You don't have to prep the teeth, assuming that the occlusion allows you to get something in there like that. And I will do that to tide them over until they're ready to have an implant. I absolutely will not prep those teeth. This is my own particular philosophy, and I'm not saying it works for everybody, but I will not prep those teeth. If they can't have an implant, I will get them by with a relatively inexpensive Maryland or Rochette style bridge. I've had them on in patients' mouths for most of them for over a decade. Okay, they do debond, and you can, because the holes in the wings are what's holding it in, you can go in with a quarter round burr, just go through each little hole and just pop it off, clean up the internal wings, roughen up the lingual aspects of the two teeth, freshen it up, etch bond, re-cement it back on. So I would rather do that and allow the patient to make a better choice for themselves down the road than say, oh, you can't afford an implant, well, I'll prep the teeth and do a 3-unit bridge. I absolutely won't do that.
Okay, final question,
My
and then we're
my
out of time.
opinion.
Final question. They wonder this all the time. They do a single implant. The most common missing tooth is a first molar, so the most common implant
Yeah.
is a first molar. Would you cement that or would you screw that?
Oh, I for 20 the first 25 years of my implant career, I cemented them. I'm doing more screw retain now. I know that, and once again, you talked about these cult and these sort of, and there are people say, oh, you've got to do cement, and other people say, oh, you got to do screw retained, and I do both. Although I did cement retained crowns for the vast majority of my implant career. I'm doing more screw retained now. And it depends. The answer to your question is it depends on what is going on in the adjacent teeth. It depends on what is happening on the opposing arch. If you have got a bruxer or a clencher, I would absolutely do screw retain so you can get it off, because under those conditions, a lot of screws will loosen under those conditions. So you're just easier. It's easier for yourself to be able to unscrew it. Okay. So I would do that in those particular situations. It also depends on the angle that the implant is placed and the path of insertion that's created by the screw exit angle. So, because having good contacts is extremely important as well, and we'll talk about the occlusion in a second. So, if you're replacing a first molar and the implant is a little off, you need to look at that screw exit angle and figure out, if I do screw retained and one of the buys is perhaps tilted a little bit, what kind of contact am I going to get with that? Now, certainly you can do an odontoplasty and distal of the buy. It depends on the degree of tilt, etc. But you got to be very, very careful. So you can't just approach it from a blanket standpoint. Again, this goes back to casts, mounted, examination, look, think, assess, all of those 5 tenets of, in my opinion, of clinical treatment. So you need to look at that, and if everything is standing straight up and everything is in beautiful alignment, and you can get a good wide implant in there, and or long implant in there, and the surgeon places it right where you want it, and the screw exit angle is coming straight up, then pick it. Pick it. I like to develop occlusions better on cement retained crowns, implant occlusions on crowns that have been cement retained. I feel I get a better occlusal result because I try to load it down the long axis of the implant. Well, that's where the screw hole is. There's nothing to load except the covering you put over it. So you're loading it somewhere else. And I don't like to load these on marginal ridges. So I want to try as best as possible to get the load factor as close as possible to the long axis of the implant. So that's another factor, is whether you're going to use cement or screw retain. So you need to get your mounted casts, look at if it's a lower molar, look at the opposing arch, look at the palatal cusp of the opposing tooth, and you don't even need to do a wax up, although at some point you may have to, and say, where is that going to land on my occlusal surface? And make a decision like that. So to me, there's pros and cons to both. I think you need to assess it. I've done both. I'm happy with both. The contacts, proximal contacts, screw exit angle, occlusion, and load factors are all extremely important, which will ultimately help you make a final decision. So.
And how can these homies contact you? What's your website? www.kennedyseminars.
Well, Kennedy Seminars is our travel company.
You've been doing these seminars
20
for
years.
20 years
Yes,
now, and
yeah.
it's mostly high-end prosthodontic education in resort fun travel locations.
It's it's outstanding education. It's not prosthodontic, it's everything. We have had periodontists, endodontists, surgeons, prosthodontists, pediatric dentists, all speak. We've to us, essentially, it's a company we started in 1996, Marshall Hoffer and I. And we started it essentially, we advertised across Canada. He and I lectured. We put the we were going on a cruise ship for a week in the Caribbean on the Regal Princess. I'll never forget it. And cruise ships at the time were so not used to doing this kind of thing. And we took, a dozen carousels, 1,200 slides in a slide packet, big, huge binder of slides. 17 dentists across Canada signed up. We went on a cruise, had an outstanding time, just fabulous time. We came back, we said to the travel agent that we had connected with, you should be doing this again. So we said, okay. So the next year we did 2 trips. We did a cruise and we went to Sandals, I think St. Lucia, 1997, and Marshall and I went. And the travel agent said to us, there's 3 ladies, Wendy, Judy, and Kathy at the agency. It's a huge international travel company, Carlson Wagonly. And I remember Wendy saying to us, if you keep doing this, you're going to get a following. And I laughed at her because I thought it was ridiculous. If she's watching this, she's going to chuckle because she was right. And we went in 1997, had a fabulous time. And then we came back and said, well, let's see where this goes. So in 98, we ran a couple of trips. And then we started adding a trip and then hiring people to lecture. And then we got our ADA CERP qualifications. We applied for that and got that. We've been CERP qualified for 10 plus years. And then the trip started to get fancier, more involved, because our customers that were coming back over and over didn't want to go to the Caribbean. They wanted to go somewhere else. They wanted to go to Europe. They wanted to go to Asia. They wanted to go to South America. So we then hired a website company and created a website. We hired a marketing company. And then the world became our oyster, so to speak. So we've been to 44 countries.
Holy moly, 44 countries?
We've been to 44
in
countries.
In 20 years?
In 20 years, we've been to 44 countries. We've done multiple Mediterranean cruises, Black Sea, Baltic, Danube, the Rhone in France. We're doing the Douro in Portugal in 17. We've been to China, Thailand, Bangkok, Vietnam. We've been to Australia. We've been to South America, Rio de Janeiro, Buenos Aires. We're doing the Antarctica in 2017, doing Spain and Portugal in 2017. We still run several hot holidays in February and March. We tie in with the Ontario midterm break in mid-March, and
Are these mostly Canadians going?
No, we have a lot of Americans coming, although I'll get to that in a minute.
Are those the lower class hillbillies?
The dentist from Kentucky. So we go to we've been going to Turks and Caicos, which is Beachels, Sandals there for, I think this is our 4th one this coming March. So that's a hot holiday. We're doing Barbados in February. So we're running a hands-on implant course in Barbados. We're running a perio course with Dr. Howard Tenenbaum, a perio oral path course in March. Jack Griffin Jr. is lecturing in Tahiti for us.
Jack Griffin Jr.? Love that guy.
Yeah, no, he's super guy. He's lecturing for us in Tahiti this coming January. We're going to Poland and Israel.
Have I done a podcast with Jack Griffin Jr.? Yeah. Can you line that up?
I can line that up.
Okay.
We're going to Poland and Israel in September, and then in 17 we have a whole list. So we actually are now spending a fair bit of time on this little side business, because it's when you're taking 100 people halfway around the world, you need to have your act together.
So it's grown to now 100 people to an event?
It's more. It's more. It can be more. Sometimes the venue restricts the number of people.
Right.
So, for instance, when we went to South Africa, we chartered the Blue Train. The Blue Train is one of the 5 great train rides in the world, and we chartered the whole train, and to the point where they actually put on a special run for us, and we went from Cape Town to Johannesburg. And we had to go on a certain day, and the train was not running that day, so they put the train on for us. So the train had 36 berths. So our trip was restricted to 36 couples. So sometimes the venue determines the number of people.
How long was the train ride?
Day and a half. That was spectacular.
Wow.
We ended up in Johannesburg, and we did lectures in Johannesburg.
I heard the train across Russia is pretty neat too.
Yeah, I've heard that too. We're not going there anytime soon, so that's not in the cards for us to go there. So sometimes the venue determines. The ship in Antarctica is a smaller ship, so they have limited cabins. So it depends. And then Turks and Caicos, we've had 200 people. So
Wow.
it varies on the venue, the time, the type of trip, and these are high quality trips. We have usually, besides myself and my wife as hosts, or Marshall and his wife Rochelle are hosts. Besides that, we'll have 4 or 5 guides. When we were in South Africa, we had guides with us right from the get-go. They flew on the, when we went on the Blue Train from Cape Town to Johannesburg, they flew and met us in Johannesburg, and they were with us all the way through the safaris. When we were in China, we flew 2 Chinese English-speaking guides from Vancouver to China to be with us. So these are top quality trips. In India, we had a driver, 3 guides, plus Debbie and I who were on that trip, hosts. So everything is looked after from A to Z, as you would
And
say in
Debbie is
Canada.
so adorable. She
Thank
is
you.
adorable.
Thank you. She does a lot of work on these.
Yeah.
Thank you. So so we are opening up the American market. Most of our Americans are along the eastern seaboard that travel with us. I think the California, Oregon, Arizona dentists, maybe they vacation differently. I don't know, because they're living in better weather all the time. So maybe they look at. I don't have an answer to that.
I think it's a statistical deal. So 3 out of 4 Americans live east of the Mississippi River,
Okay.
and 2 out of 3 live within 500 miles of Washington D.C.
Okay.
So no matter what, if you're talking about eating candy bars or drinking Dr. Pepper or whatever, it's all in the Northeast. Because I mean, if you fly from New York to Phoenix, I mean, at the first hour out, it's just all lights that you see, and then it's just pure darkness. So there's just no density out there. And from the Mississippi, it's not until you get to about California where 10% of Americans live.
Okay.
But there's just not any bodies.
So I think they might vacation differently. I mean, I honestly don't know.
Well, it's probably an equal sampling per 1,000 dentists.
Yeah.
It just shows up looking like it's all in the Northeast.
Okay.
But it's probably an
Yeah.
equal.
So we are. We have an outstanding seminar coordinator now. Her name is Roxanne. She is superb, talented, organized, and she thinks out of the box. And so she is now really pushing the envelope on what she wants the company to do. And so we are now, starting in 2016, we are going to have an unofficial connection with the FDI. FDI is in Poland in September 2016. So we're doing we're doing a pre-FDI trip in Poland for 5 days and a post-FDI trip to Israel. In 2017, the FDI is in Madrid, Spain. So we're doing a pre-Madrid trip for a few days and a post-Madrid FDI trip, Portugal Douro River cruise. And a post trip, we're going to go to Lisbon for a few days. So there's that. So we're unofficially tying up with the FDI because we're not connected with them. We'd like to be, but we're making some communications. And what we're doing now with the American market is we're now polybagging the ADA News. We used to advertise 2 or 3 times in the ADA News, which is how we picked up our American customers. And we're now polybagging. So we're putting a one-page brochure, for lack of a better word, in the, I believe it's the late January edition of the Polybag, the ADA News. So it's going to go out to 180, 200,000 dentists in the United States, whoever gets the ADA News. And we're going to be at the Chicago Midwinter with a booth. So we're pushing the envelope.
When Chicago Midwinter? February?
Yeah, February. Okay. So we're pushing the envelope. It's we have had customers return 5, 10, 15 times. Many of our trips, half are returnees, multiple times, and new people, obviously, of course. So you talk to any of our customers. These are well-organized, outstanding trips. And the CE is top quality. We hire top quality lecturers, researchers, clinicians, and so the CE is excellent, certified by the ADA CERP. So you go, and interestingly enough, when we did our first trip in 1996, 100% of the dentists signed up, stayed for the lecture. Right now, over the last 20 years, our retention rate in the lecture is probably around 80-85%. So what's interesting, which I think is wonderful, is that dentists really want to learn. And when you're sitting on a boat and you're in the Caribbean and it's 85 degrees Fahrenheit outside and the sun is shining and the waters are blue and you're sitting in a lecture theater and you're not leaving. And I hosted a lecture where they actually, when the lecturer quit, they actually told them to show another hour's worth of material. When you're when you're on a cruise ship and you're sitting in a lecture theater, you want to learn something. So it's heartwarming to see. So it's been a wonderful experience, and I would encourage everybody to get onto our website and take a look.
And I just one more reason. I mean, I love dentists. They're huge readers.
Yes.
They love to learn. That, no matter what country you go, they've got 5, 6 to 10, 12 years of college. They're always top 5% income. It's great hanging out with dentists. But what I can say is that when you go to a foreign country by yourself, you don't even know what to do. You don't know where to go. When you go on guided trips, I mean, I've gone to so many countries, and when you go in on a guided trip, it's so much more fun and rewarding.
And the bond is there because everybody's a dentist. They don't talk about teeth, but they have a commonality.
I'll give you a classic example. After living in Phoenix for 20 years, one time we were staying at the resort, and they always have this pink Jeep tour in Sedona. And all the tours do it. And we just sat there and thought, well, you know what? Why don't we just go on it? I mean, we live here. We don't need that. My God, I can't believe I missed that for 20 years. That was the coolest thing I'd ever seen in Arizona, but it wasn't on a tour guide.
I think
thank you so much for your time.
Thank you. It was wonderful. Thank you very much. I enjoyed talking to you.
You're an amazing man.
And I enjoyed your lecture yesterday. It was outstanding. People are still talking about it.
And what a guest. The party afterwards and the Polar Bear Museum and the human rights.
The polar bears were we just hit that on the nail, watching those bears swim in the water. Yeah.
All right. Well, good
seeing you.